Morning, everyone. Welcome to the Olympic rounds. It's the first time I've seen Jason wearing a tie in quite some time. So this morning we're going to have a review of testosterone replacement therapy, and Jason Sia, who I think everybody should know is one of our R3s, is going to present. So Jason, take it away.
Thanks, Dr. Goldenberg. Good morning, everybody, and thanks for coming. So my talk today is the topic of androgen replacement in late onset hypogonadism. Steroid use in sports has received a bit of attention in the press since the synthesis of steroids originally in the 1930s. There have been multiple instances in which athletes have used these steroids to gain an unfair advantage over their competitors. Some of the more famous or infamous of these characters include Ben Johnson over here, as well as Mark McGuire and Alex Rodriguez. And does anybody recognize this young lady over here in the middle? Exactly. Cornelia Enders, that was one of the Olympians back in 1972 and 1976. She smashed approximately 30 Olympic records, and it was later revealed that the Germans were using steroids systematically in their training programs. So with the Olympics upon us here in Vancouver 2010, I thought it'd be interesting to note the number of banned substances in the games. This is recorded with the World Anti-Doping Agency, and they have quite the task set ahead of them as athletes try to get more sophisticated methods to defeat their detection methods. So this was recently in the news, gene doping as the newest way of cheating. In the Vancouver Sun, February 5th, 2010, we see an article on gene doping, which is the insertion of erythropoietin into the human chromosome through the use of a vector, viral vector here, inserting EPO into the chromosome, resulting in more red blood cell production and unfair advantage. So back onto the talk itself, we're going to go through a little bit of the biochemistry, physiology, diagnosis, treatment options, concerns regarding testosterone replacement, and finally monitoring and follow-up. I'd like to start off with a few presentations to get you guys thinking about the topic. So presentation number one is a 60-year-old male with symptoms of hypogonadism in terms of decreased libido, erectile dysfunction, and fatigue. He's overweight with a BMI of 45, but surprisingly otherwise healthy. Has a total testosterone of 10.4. And
please enter your conference ID. Press the pound key when complete.
Okay. So, a show of hands here. Who would choose to replace testosterone in this case? Nobody? Who would choose to repeat tests? A few hands there. And who would choose no treatment in this case? And a few hands over there as well. Patient presentation number two, a similar gentleman, 55-year-old gentleman with similar symptoms of libido, decreased erectile dysfunction, and fatigue, but different in this case with a positive biopsy for high-grade PIN. This guy has a lower total testosterone of 7.8, which I can tell you is in the low range. Who would choose to replace testosterone? Show of hands. And who would choose no treatment? So about, I guess about equal. Number three is a 65-year-old gentleman with, again, similar symptoms, but in this case with a significant history of retropubic prostatectomy for prostate cancer, now has undetectable PSA. Who would choose replacement of testosterone in this case? So about half the audience. And who would avoid treatment? And a few hands there. So moving on to the biochemistry of the androgen receptor, it's located on chromosome X, belongs to a larger family called the nuclear receptor family, which includes estrogen, progesterone, as well as glucocorticoid receptor. Testosterone receptor has two isoforms. These isoforms are both divided into 4 domains, and its main ligand is testosterone or DHT. So we have a pictorial representation over here with the N-terminal on the left side being a platform for receptors and co-receptors to form upon. The DNA binding domain in the middle here, which is a conserved region of 2 zinc fingers allowing interaction with DNA, and the ligand binding domain, which is close to the C-terminal, which allows interaction with DHT and testosterone. And the interaction with DHT is 5 to 10 times more potent than testosterone. So the androgen receptor is usually located in the cytoplasm, and upon binding to testosterone gets translocated into the nucleus, where it exerts effects onto the DNA of the cell, causing expression of over 100 genes. One of these genes is PSA, which we use for monitoring of activity. Another look at the mechanism of testosterone receptor, we see that the active form is actually a dimer of the 2 receptors with testosterone bound and phosphorylation occurring on the molecule. As we see over here, the bound and active molecule sits on the androgen receptor element and causes recruitment of transcriptional machinery and subsequent transcription and translation of the genes. Moving on to the physiology of testosterone, we know that testosterone is important early in life. It starts exerting its effect on the male embryo, causing differentiation into the male phenotype. Additionally, testosterone has important effects in the adult male, in which it's involved in maintaining health. The aging male has been shown to have decreases in testosterone, and the testosterone is controlled through the hypothalamic pituitary gonadal axis, which involves GnRH and LH and FSH. Multiple body systems are affected by testosterone, and we'll talk about this a little bit more. So important is the distribution of testosterone, and the most freely available testosterone is free testosterone, which is available in approximately 2%. Bound testosterone also includes loosely bound fraction to albumin, which is in conjunction with free testosterone considered the bioavailable fraction. A significant amount is bound to serum hormone binding globulin, which is not available to the body. We have a pictorial representation of the axis over here with the hypothalamus sensing testosterone and with low levels signaling to the pituitary with GnRH to release LH and FSH in a pulsatile fashion to the Leydig cell, as well as to the Sertoli cell, causing production of testosterone as well as induction of spermatogenesis. So we'll go through the next few slides pretty quickly. Testosterone has many effects on the body. In the brain, it's responsible for cognition as well as reproductive and non-reproductive behavioral patterns. In terms of mood, testosterone has been shown to increase mood. It's also been shown to have positive effects on sexual function. Some studies have demonstrated increased frequency of sexual events as well as increased performance with testosterone. Importantly, testosterone has also been shown to work in conjunction with PDE5 inhibitors to improve erectile dysfunction. In the bone, testosterone is Dr. McLaughlin?
Is the T directly or metabolite T works in the brain?
I didn't come across that. Yeah. So testosterone in the bone exerts its effect on the osteoclasts and osteoblasts. It's been shown to affect bone mineral density levels. Hypogonadism has been shown to be linked to low BM bone mineral density, whereas replacement of testosterone has been shown to improve that. However, no data in terms of testosterone preventing fractures has been released as of yet. In cardiovascular disease, importantly, it has been shown not to negatively impact cardiovascular function, but on the contrary has been shown to improve cardiac index, as well as low testosterone levels have been shown to be linked to increased cardiovascular risk. So with this slide here, I just want to illustrate that testosterone deficiency syndrome is known by various names, and that there is ongoing debate about what the best terminology is. The diagnosis of testosterone deficiency requires both clinical and laboratory values. We must exclude confounding factors and medications that might interfere with diagnosis. And some of these are listed over here. So depression, hypothyroidism, alcoholism, and a number of medications which might interfere with testosterone metabolism or testosterone secretion. The clinical symptoms of testosterone deficiency can be quite vague. They include low libido, erectile dysfunction, decreased muscle mass, increased fat, decreased bone mineral density, as well as decreased mood. In other areas of medicine, we often use screening questionnaires to pick up disease. For the case of androgen deficiency, these questionnaires have high sensitivity, as you see with the ADAM questionnaire. They've reached a 97% sensitivity. However, with all these questionnaires, they have low specificity, and this is due to the vagueness of the symptoms associated with testosterone deficiency. The conclusion with the questionnaires was that they weren't particularly helpful in picking up patients due to their low specificity. This is an example of one of the questionnaires, and you can notice from the questions that they are sometimes quite vague, and we can see why the specificity is low. So one group tried to correlate the questionnaires on a Likert scale to the level of testosterone, and they found a correlation, however, not a really good R value, and no values in the low questionnaire region, as well as no values in the lower serum levels, so a few deficiencies there. In setting the level of testosterone that is low, we go back to our epidemiologic studies, and this is quite a busy slide, but the main points I want to make here are there were a couple main longitudinal studies, as well as a number of cross-sectional studies. They used various criteria for their cutoff of hypogonadism. Some of these studies used a cutoff of 2 standard deviations, whereas some of these studies used a cutoff of 2.5 standard deviations. And as the definition of hypogonadism became more refined through the Endocrine Society, some of these later studies here at the bottom also started including criteria requiring symptoms. As a result, we see that the prevalence in these studies differs, with some of the earlier studies having up to 50% prevalence in some of their groups of patients, whereas the newer studies may have a lower prevalence. This being said, they do all agree that testosterone decreases with increasing age. And this is data from the most recent study. I just wanted to illustrate that testosterone decreases with age, but free testosterone decreases even more sharply than total testosterone. Additionally, serum hormone binding globulin increases with age, and as we remember, this would work to decrease the total amount of bioavailable testosterone available to the body. So have we reached a consensus in terms of what is low for testosterone levels? Not exactly, but a consensus statement by the Endocrine Society state that above 12 nanomoles, you're likely not to require replacement. Below 8, you could likely benefit, and in between is a gray zone, which requires further differentiation. We have to remember that testosterone is cyclical in terms of its nature. On the left, we have a study that demonstrates the diurnal cycle of testosterone with peak levels in the early morning, requiring testosterone to be tested between the hours of 7 to 11. Additionally, we also have variations in testosterone on a weekly cycle, as we see with a few various patients plotted along a weekly trend here. This particular patient was eugonadal at times, but hypogonadal at other times. So that warrants repeating the test if suspicion is high enough.
One is American units on the right, the other is
Right.
international units. So
Right.
Can you just base it or
Yeah.
round this again?
I want to touch base on it actually. So the studies are done both in American and international units. Just as a rough guide, 230 in American units, which is nanograms per deciliter, is equivalent to 8.4 nanomoles per liter in our units. 350 is equivalent to approximately 10.4, and 15 is, 400 is equivalent to approximately 14 or so in the units. So touching briefly on testosterone assays, the most available form is free testosterone, but it's a very tedious test to perform. The gold standard is equilibrium dialysis, but it's very time-consuming and laborious. However, this study demonstrated that calculated free testosterone correlates well to the gold standard, which is equilibrium dialysis. So therefore, we can use calculations to get the free testosterone. That involves calculating the total testosterone as well as the serum hormone binding globulin. The laboratory testing for testosterone deficiency proceeds as depicted. A low morning testosterone may cause a clinician to repeat total testosterone if they are suspicious that there are possible errors in the lab, or if the timing of the test was wrong. As we mentioned, that testosterone must be performed in the early morning. For those who have really low testosterone levels, you might want to consider LH and FSH, as well as prolactin levels to further differentiate. In our aging male, it's unlikely that we're going to be picking up primary hypogonadism, though. This slide is important in terms of differentiating which patients with low or gray zone total testosterone may need further differentiation. So as we mentioned, greater than 12 doesn't usually require further differentiation or treatment. Less than 8 usually will benefit, but the gray zone 8 to 12 can benefit from further testing. This includes repeat testing of total testosterone itself, or differentiation into free testosterone and further workup with LH and FSH. So why not do free testosterone on everybody? Well, as with a lot of other things in medicine, it partially comes down to cost. And we see here that the bottom line is a assay for free testosterone results in approximately a threefold cost. So at one of these laboratories, $37 for the free testosterone versus $12 for the total testosterone. So we go back to patient presentation number 1. This gentleman, we now know, had a total testosterone in the gray zone. He had a high BMI of 45, which might affect serum hormone binding globulin. And in this case, it would be reasonable to repeat testing. We'd want to make sure that the testing was done at the appropriate time, and we might consider further tests to differentiate into total testosterone or bioavailable testosterone. Therapeutic options for testosterone are many. There's 5 main categories, including oral, buccal, intramuscular, transdermal, and subcutaneous. The implants are the newest of these formulations, and they last for approximately 6 months. The drawback from this particular form is mainly in the extrusion of the of the implant from the site, as well as local irritation and possible infection. Intramuscular formulations have been around for quite a while now. They also last for a fairly long duration, requiring replacement every 2 to 3 weeks, but have drawbacks of spiking of testosterone levels, and patients often complain about pain at the injection site and frequent visits to the doctor's office. Oral medications have probably been around the longest and previously were associated with hepatotoxicity. However, the newest forms in the undecanoate have improved and are no longer associated as much with hepatotoxicity. They require frequent dosing every day. Transdermal, which are the most popular, also require dosing every day and are associated with local skin irritation and possible transference to partners within the family if patients aren't careful. Buccal forms are also a new formulation and require everyday dosing. So let's talk about the contraindications of testosterone replacement, and this includes prostate cancer, breast cancer, those patients that have liver disease, as well as those who have erythrocytosis, COPD, and CHF. There are also controversies in terms of testosterone replacement in prostate cancer and in high-risk patients of prostate cancer. So in talking about testosterone replacement in prostate cancer, I'd like to begin by couching it with the seminal study performed by Huggins and Hodges, which demonstrated biochemical and clinical response of metastatic prostate cancer to androgen deprivation therapy. And this forms the basis of our treatment for advanced prostate cancer and metastatic prostate cancer. So with this in mind, it's reasonable to question the safety of testosterone replacement in the setting of prostate cancer. A few questions that we have to answer are: what is the effect of testosterone level on prostate cancer risk? Is testosterone safe in these patients? And what about those patients that have been successfully treated for their prostate cancer? So starting off with what we do know about the relation of testosterone to prostate cancer, we know that eunuchs do not develop prostate cancer, as well as patients that have androgen insensitivity syndromes. We know from Huggins and Hodges that androgen deprivation therapy causes regression of metastatic prostate cancer. And we know from recent trials, including the PCPT, that blocking of testosterone to dihydrotestosterone demonstrates a 25% reduction in the prevalence of prostate cancer. Similarly, the REDUCE trial supports the PCPT trial with similar results. In going back to the observational studies that try to delineate the association of testosterone to prostate cancer, we have a few meta-analysis of prospective studies. One of the older studies back in 2000 looked at 28 prospective studies, mainly cohort studies and case control studies, and only selected 3 out of these 28. They demonstrated 2.5 times risk in the highest quartile of testosterone compared to the lowest quartile. However, a more recent study, also based on prospective observational studies, demonstrated no correlation, and this is their data. So they had 3,800 patients that had prostate cancer, and they compared this to approximately 6,000 matched controls. And from this table here, what we can see is that they did not see any change in relative risk of their lowest quintile to their highest quintile between any of these factors, including testosterone, free testosterone, DHT, DHEAS, and androstenedione.
Was the lowest quartile hypogonadic? I can't
No,
know.
these were,
All quartiles within the normal range.
yeah, these were all patients that were just normal. These weren't particularly hypogonadal patients. The next study that I'm going to present is that situation.
So if you look at the lowest quartile, what is that lowest?
They-
Whatever it's called.
They didn't actually talk much about the actual range that their patients fell within. They just listed the relative risks. So as Dr. Gleave was asking about, what about hypogonadal patients, and what's the relation of testosterone in hypogonadal patients? Well, Morgenthaler and Roden performed a observational study on 345 patients that were found to be hypogonadal. And what they did was biopsy all these patients prior to replacing testosterone. What they found was that there was a similar prevalence of prostate cancer in these hypogonadal patients to the control arm of PCPT. So they found that there was approximately 15% prevalence of prostate cancer. However, a few points to highlight about this study are that their PSA levels were less than 4, and the reason for biopsy in this case was all hypogonadal men, which is not the usual reason why we biopsy patients. The usual reason being either a abnormal DRE or a rise in PSA. So these patients might be different in terms of So, back from the intermission,
they're working on it. He's going to give me a call as
proceedings there are able to sort it out.
Okay. So additionally, within their data, they looked at the subset of patients that had prostate cancer and looked at their characteristics and noted that the patients with prostate cancer had severe levels of hypogonadism, which was an interesting finding and supported by other studies that I haven't discussed in this talk. So there are a couple of reasons postulated for the relationship that was seen. First of all, testosterone receptors in animal studies was noted to be saturated at a very low level. This is approximately 2 nanomoles per liter. And because testosterone is saturated at such a low level, in the human body, when we're at physiologic levels or even close to physiologic levels, the prostate cancers are indifferent to the amount of testosterone that's available. That's one postulated mechanism. Another postulated mechanism that was presented by a group led by Marx was that the level of testosterone in the prostate didn't correlate well with that in the serum. And what they did was take 44 patients and randomized them to testosterone or placebo group, demonstrating that in the serum, on the graph on the left, that post-treatment at 6 months, we see serum levels of testosterone rising above the level at baseline, whereas in the prostate, there was no significant increase in testosterone, and similar trend was seen for dihydrotestosterone. So where does that really leave us in terms of the relation of testosterone to prostate cancer? Well, we know that there has been an established link between testosterone and prostate cancer through the study by Huggins and Hodges, our PCPT data, as well as the reduced data. But the interaction of testosterone and its role in prostate cancer is complex, and we don't know all the details about this at this point in time. Of note, epidemiologic studies are not able to demonstrate a causative relation between testosterone and prostate cancer. So moving on to randomized controlled trials, Kaloff and their group did a meta-analysis of 19 randomized controlled trials in which men were randomized to testosterone replacement or placebo group. Their criteria were that men were over the age of 45 and had a minimum of 90 days of treatment. The mean and median were closer to 10 months of treatment, and they had 600 patients in the testosterone group and 400 in the placebo group. In analyzing events defined as prostate cancer, PSA rise, and the triggering of prostate biopsies, they found no statistical difference. The most common event associated with testosterone replacement was a rise in the hematocrit, which was approximately a 4-fold risk. Kind of changing gears again, the question of whether testosterone is safe in high-risk patients. Rodin did a study that they carried out in patients with PIN. Testosterone replacement was carried out in these patients for 12 months, and these patients received biopsies before and after testosterone replacement. They also had a control group which was monitored for incidence of prostate cancer, and what they noted was in the treatment group, 3 patients underwent prostate biopsies for a abnormal digital rectal examination, and 1 went on to have a confirmed prostate cancer, Gleason 7. However, if we look at previous data on PIN, we'd expect that number of patients to progress on to prostate cancer anyways, with the rate of positivity on repeat biopsy approximately 25% in a patient with high-grade PIN. So going back to patient presentation number 2, this gentleman had PIN and otherwise was stable. So it is reasonable to replace testosterone in this patient with the current data that we have right now.
So Jason, would you, it's a question as well, you're going to give T for symptoms of hypogonadism, would you also add Abidar to your approach?
Yes, that's another relevant question. I believe a few of the studies did add Abidart or Proscar to keep the risk of prostate cancer progression or incidence lower than if they hadn't been on medication.
Unless your T levels are really low and really close to castrate, I'm not sure that makes a difference. I think those are two different treatment mechanisms. Bringing T from a moderately low level into the normal range because of the androgen receptor saturation issues, I doubt makes a difference. I mean, I don't think there are any studies.
If you go back, there are no studies, but you know that 5-alpha reductase inhibition will lower that guy's chance of having a positive biopsy by 25%.
So that would be separate than bringing his, that doesn't really matter what his initial T is, though, right?
Yeah, but it does make sense because as far as at least the libido component is driven by T.
Right, so if you didn't do T,
So if you give T and give finasteride,
that just gives you a higher level of your serum testosterone.
well, it would do that, but it would also reduce the VHT.
That's the point. He's high risk for prostate cancer.
Correct.
He should get
Yeah.
finasteride.
Yeah, ASAP, you will get more concerned.
Yeah.
So
There's
it's only, the study is only 1 year of testosterone replacement.
Right.
It's a little bit early.
No,
There-
he's high risk anyways because he's got an elevated PSA and he's got PIN.
Whatever.
yeah. So back in there's no studies on the ASCAS, but that would definitely be even higher risk, as Dr. Goldenberg mentioned. So moving on to the studies that look at testosterone replacement post-prostate cancer treatment, specifically in the setting of post-prostatectomy, there were 3 studies that were carried out. The literature do not demonstrate any clinical progression in these cases. So going through these studies in more detail, the most recent is by Kara and his group back in 2009, where 57 patients receiving testosterone therapy post-prostatectomy were followed for a mean of 13 months, and they had no progression in terms of their PSA values. They all stayed less than 0.01. Similarly, Agarwal and Olafin back in 2005 had a similar study but with less patients, and they also found that PSA levels did not progress. They followed their patients for approximately 19 months. And a third study with even fewer patients, 7 in total, performed in 2004 with, again, the same results. So a summary of these 3 studies: we have a total of 74 patients that have been studied post radical prostatectomy with testosterone replacement and had no progression of their disease. So we can go back to patient presentation number 3 at this point. This gentleman falls into that category of prostate cancer that has been treated with radical prostatectomy and has undetectable PSA and no evidence of recurrence, and therefore it does appear safe at this point in time to replace the testosterone. Yep. Additional study on post-brachytherapy patients demonstrated similar results with obviously different criteria due to these patients requiring brachy rather than radical prostatectomy. So their enrollment was mainly patients that had T1C and Gleason 6 prostate cancer, with 5 of these patients dropping out because of no benefit. But with follow-up at approximately 5 years, they noted that their PSA was still less than 1, which was noted as a confirmation of no progression of disease. So where do we aim to replace the testosterone levels to? And we just talked about this briefly. So each patient's going to have a different normal range of testosterone, and it's difficult to identify exactly what the normal range is. However, the current guidelines note that target level of testosterone should be in the mid to low level of normal as defined by the epidemiologic studies that we have currently. We'd like to avoid any sort of supraphysiologic levels. We would, in this case, initiate therapy with short-acting agents so that they could be discontinued easily. And we'd monitor for hematocrit, as that is the most common side effect.
Jason, do you have a time of day you recommend that test be done?
Which one?
To do the T?
The T? Yeah.
Early morning, midday?
Yeah.
It makes a big difference.
Yeah, definitely. So going back to the slide with the diurnal variation, with the peak level of testosterone in the early morning, the testing would be recommended at between 7 o'clock and 11 o'clock in the morning. So the monitoring of patients on testosterone replacement therapy also requires reassessments of testosterone level, a regular digital rectal examination, PSA levels, hematocrit, liver enzymes, lipids, as well as bone mineral density. And this is recommended to be performed initially on a more frequent basis at the 3, 6, and 12-month mark, and then thereafter on a yearly basis. So in summary, testosterone is a critical hormone in the male as well as female, has a wide effect of effects on various body systems. The low levels of testosterone can negatively impact a male. The diagnosis requires both clinical and laboratory findings, and we have to keep in mind that the testosterone levels are cyclical in terms of the testing for, in terms of the lab testing. Our levels of low are not well defined at the current moment, but in general, the guidelines state that less than 8 could probably benefit, or free testosterone less than 225 would likely benefit. There's many therapeutic agents, and you would have to tailor this to your specific patients. And the current data demonstrate that testosterone replacement is safe, particularly in patients post-prostatectomy and post-brachytherapy, with limited data at this point. Thanks.